Welcome back to the deep dive. Today, I want to invite you on a walk. But fair warning, this isn't going to be a casual stroll through the park. We are taking a radiologic walk through the human body, looking specifically at the story of rheumatoid arthritis. And I have to be honest, when I first saw the title of our source material, this presentation by Dr. Lucia Martinez-Vega and her colleagues, I thought, okay, lots of black and white pictures of bones.
Right.
But as I started digging in, I realized this is actually, it's a detective story.
It really is. It's a detective story where the clues are hidden in shadows and these subtle shifts in bone density. And it's a story that needs to be read very, very carefully because the stakes are incredibly high.
Yeah.
We aren't just looking at medical images here. We're decoding a chronic autoimmune disease that systematically, dismantles the architecture of the body.
And that is a terrifying way to put it, but
Yeah.
accurate. So our mission today is to figure out how to read that visual language. How do radiologists spot REA? How is it different from, say, the arthritis my grandmother has in her knees? And the thing that really stuck with me, and I want to spend some real time on this, is this concept of the bare area.
The bare area, yes. That is probably the single most important anatomical concept to grasp if you want to understand this disease.
Really?
Yeah.
Yeah.
It explains why the damage happens exactly where it does. It's not random at all.
We will definitely unpack that. It feels like we're about to put on X-ray specs. But before we start looking at the bones, we need to understand the enemy.
Right.
What exactly is rheumatoid arthritis? Because I think a lot of people just hear arthritis and think, aches and pains.
Right, and that's a dangerous misconception.
Right.
RA isn't just getting old or wear and tear. It's a chronic autoimmune disease. Basically, your body's defense system gets confused.
Refused.
It launches a full-scale assault on itself, and specifically, it targets the synovium.
The synovium, that's the lining of the joint, right?
That's it, yeah. Correct. Imagine the joint is like a sealed room. The walls of that room are lined with this soft tissue called synovium. In RA, that lining gets inflamed. We call that synovitis.
Synovitis.
It becomes hyperplastic, meaning it just overgrows, and hyperemic, which means blood flow rushes to the area.
So it's swollen and angry.
Exactly. And this isn't just a mechanical swelling, it's a chemical storm. You have this flood of cytokines, things like TNF-α, interleukin-1, IL-6.
Those are the signaling proteins that tell the body we are under attack, aren't they?
Yes.
Yeah.
But in this case, they are the attack. They call in immune cells, T cells, B cells, to keep the fire burning. And here is the vicious cycle.
Oh.
This inflammation leads to bone destruction. But the bone destruction releases factors that cause more inflammation. It just feeds itself.
It's a runaway reaction. Now, this brings us to that concept you mentioned earlier, the bare area. In the source material, they treat this as ground zero for the disease. Why is this specific spot so vulnerable?
Okay, so this is where anatomy meets pathology. Picture a bone inside a joint, say, the end of your finger bone.
Okay.
The part of the bone that actually touches the other bone is covered in cartilage. Think of cartilage like a hard hat or a shield. It's tough, it's slick, and it protects the bone.
Okay, so the top of the bone is wearing a helmet.
Right. But the joint needs to be enclosed by that capsule we talked about, the synovium. The capsule has to attach to the bone somewhere.
Right.
It attaches just below the cartilage helmet. So there is a tiny millimeter-wide strip of bone that is inside the joint. But it doesn't have the cartilage helmet. It's just bare bone covered by that soft synovium.
Oh, I see. So you have the helmet, and then you have the exposed neck before the armor starts again.
That is a perfect analogy. It's the exposed neck.
Yeah.
So when that synovium gets inflamed and turns into this aggressive sort of weed-like tissue we call pannus, it is sitting directly on top of that naked bone. There is no shield. That is why the bare area is where the erosions start.
That makes so much sense. And it makes me wonder, is that just a design flaw in humans?
It's an evolutionary trade-off.
Yeah.
We need that attachment point to be flexible so we can move our fingers and wrists. We traded total protection for mobility.
And RA exploits that trade-off.
It absolutely does.
Wow, that is fascinating and slightly depressing. Okay, so we know the mechanism. Now, let's talk diagnosis. If I walk into a clinic with joint pain, how do you know it's RA and not something else? The source mentions a kind of scorecard.
Yes, the Acreler classification criteria. It's effectively a point system. You need a score of 6 out of 10 to get a definitive diagnosis of RA.
A 6 out of 10. Walk us through how you get points.
Well, the biggest chunk of points comes from joint distribution. Basically, how many joints are hurting and which joints.
Okay.
RA loves company. It rarely hits just one spot. And crucially, it targets small joints.
Hands and feet.
Exactly. If you have inflammation in one big knee, that gets you fewer points than if you have inflammation in, say, 5 little finger joints.
Okay. What about blood work? I know people talk about rheumatoid factor.
They do, and that's part of the score. We look for rheumatoid factor, or RF, and something called ACPA anti-citrullonated protein antibodies.
That is a mouthful. Which one is more important?
The ATPA is the heavy hitter. See, rheumatoid factor is actually not that specific. You can have it with other conditions or even just old age.
Oh, really?
But ACPA, if you have high levels of ACPA, it's almost certainly RA. And it usually signals that the disease is going to be aggressive. It predicts a worse outcome.
So ACPA is the smoking gun.
Essentially, yes. Then you add points for duration. Has it been more than 6 weeks? And for inflammatory markers in the blood, like CRP. If you hit 6 points, we start treating.
Right. Now, once you suspect it, you need to see it. We have all this technology, MRI, ultrasound, but the source says the plain old X-ray is still the cornerstone. That surprised me. Why rely on 100-year-old tech?
It does seem counterintuitive, doesn't it? But X-ray is kind of this sketch artist of the medical world.
Huh, I like that.
It's fast, it's cheap, and it's everywhere. But its real value is in seeing the history of the battle. X-rays are excellent at showing bone damage, those erosions we talked about.
So it shows the scars.
It shows the scars and the structural failures. It gives us a baseline. If you come in on day 1 and you already have erosions on an X-ray, I know we are behind the curve.
But X-ray has a blind spot, doesn't it?
A huge one. It cannot see the soft tissue. It can't see the inflammation itself, only the damage the inflammation causes later.
So if you want to catch the criminal before he smashes the window, you need something else.
And that's where MRI comes in. MRI is the high-definition surveillance camera. It can see the bone marrow edema swelling inside the bone long before the bone actually erodes.
Wow.
It detects the threat before the damage is permanent.
Why not just MRI everyone then?
Cost, time, accessibility, and frankly, it's uncomfortable for patients to lie still in a tube for 45 minutes if their joints hurt.
That's a good point. And ultrasound.
Ultrasound is like the live news feed on the ground. It's real time. We can put the probe on a joint and see the blood flow, the hyperemia, right then and there.
Oh.
Plus, if I need to stick a needle in a joint to drain it, I'm using ultrasound to guide me.
Okay, so we have our tools. Now begins the detective work. The source outlines 8 specific radiologic findings or clues. I want to go through these not just as a list, but as what a radiologist is actually hunting for.
Let's do it.
Clue number 1 is distribution. You mentioned small joints, but there is a very specific rule about symmetry here, right?
Yes. RA is a symmetrical disease. If your right knuckle is inflamed, your left knuckle is almost certainly joining the party.
A mirror image of pain.
Pretty much, yeah.
But here's the detail that it blew my mind. It attacks the knuckles and the middle joints of the finger.
The DIPs, yep.
But it completely skips the fingertips.
The DIP joints, distal interphalangeal joints, yes. This is one of those useful diagnostic clues we have.
Why? Why would the disease travel all the way down the arm, destroy the wrist, destroy the knuckles, and then just stop an inch short of the fingertip?
We don't fully understand the molecular why, but we know the pattern. If a patient comes in and their pain is mostly in the fingertips, the DIPs, I immediately think this isn't RA.
So what is it then?
It's probably osteoarthritis or psoriatic arthritis.
So fingertips usually equals wear and tear, knuckles equals autoimmune attack.
Broadly speaking, that is a very safe bet.
Okay, next clue. We talked about the bare area and erosions, but the source had a really interesting tip about where to look for these erosions first. It's not always the hands.
No, and this is a classic mistake. You can have a patient with hand pain, but the x-rays of the hands look fine.
Okay.
A smart radiologist will x-ray the feet.
The feet?
Specifically the 5th MTP joint, the base of the little toe. For some reason, erosions often appear there first. The feet can be the canary in the coal mine for RA.
That is wild. So my hand hurts, but my toe holds the proof. Let's talk about clue number 3, osteoporosis. Now, I usually think of osteoporosis as something that happens to your whole skeleton when you get older.
Right.
But this is different, right? This is local.
This is periarticular osteoporosis. Peri means around, articular means joint. It happens specifically around the inflamed joint. Remember that increased blood flow?
The hyperemia.
Right. That blood flow washes out minerals and activates osteoclasts, the cells that eat bone. So the bone gets weak and porous right next to the inflammation.
It's like the fire of the inflammation is melting the nearby structure.
That's a great way to put it. And it creates a very distinctive look on the x-ray.
Yeah.
You see a dark, washed out band of bone right at the joint margins.
Okay. Moving on to another clue. Cysts. The source calls them geodes, which sounds like a rock you'd buy at a gift shop, but I'm guessing it's not as pretty.
Not quite. Think of it like a sinkhole forming under a road. The pressure from the pannus, that inflammatory tissue, pushes fluid or tissue into the bone, creating a cavity.
And if you have a sinkhole under the road,
The road collapses. These cysts make the bone incredibly prone to fracture.
now we have to talk about the deformities. This is what people see in late-stage RA. The twisted hands. The source lists things like ulnar deviation and swan neck deformity. These terms, they sound almost elegant, but the reality is brutal.
It is. These deformities represent the failure of the entire mechanical system. Ulnar deviation means the fingers drift sideways toward the pinky side.
Wow.
Imagine trying to open a jar or turn a door handle when your fingers are literally pointing the wrong way. The tendons have slipped off their pulleys.
And the swan neck.
That's where the middle knuckle bends backward and the tip bends forward. It locks the finger. You lose the ability to make a fist. You can't grasp things. It's a profound loss of function.
It really highlights why catching this early is so important. We aren't just trying to stop pain, we're trying to save the ability to use your hand.
Precisely. We are trying to preserve independence.
Now, we've covered the hands and feet, but there is one section in the source material that really stood out as the danger zone. The cervical spine, the neck.
This is the life-threatening part of RA. We tend to focus on the visible deformities in the hands, but the neck involvement is silent and potentially deadly. Up to 50% of RA patients have some involvement here.
And it's specifically the top two vertebrae, C1 and C2.
The Alice and the axis, yes. These are the specialized bones that let you nod yes and shake your head no.
And what happens to them?
Well, C1 is a ring, and C2 has a peg sticking up the odontoid process. It looks like a tooth. C1 rotates around that tooth. It's held in place by ligaments.
Okay.
RA destroys those ligaments.
So the ring starts sliding around on the tooth.
It slides forward. That's called anterior subluxation. And remember, the spinal cord is running right through that ring just behind the tooth.
So if the ring slides forward,
It acts like a slow-motion guillotine on the spinal cord.
that is a terrifying image. The source mentions measurements here, 3 millimeters, 9 millimeters. Can you help us visualize what we're measuring?
Sure. On a side view x-ray, we measure the gap between the back of the C1 ring and the front of that tooth. Normally, they should be hugging tight less than 3 millimeters apart.
And if it's more?
If that gap opens up, it means the ligament is gone. If it opens up to 9 millimeters or more, the spinal cord is being crushed.
And there's another type of slip called cranial settling, which sounds like a house settling into its foundation.
That's effectively what it is, but the house is your skull, and the foundation is your spine. The side masses of C1 collapse due to erosion. So the C2 vertebrae, that tooth physically pokes upward.
Pokes upward into where?
Toward the brainstem, the medulla oblongata. This controls your breathing, your heart rate.
Tom, this isn't just my neck hurts. This is I could stop breathing.
Correct. And this brings us back to why MRI is so vital here. X-rays show the bone slipping. But remember the pannus, that soft inflammatory tissue.
The weed.
The weed grows around that tooth, the odontoid. You can't see the weed on an X-ray. But that massive tissue can get big enough to strangle the spinal cord even if the bones haven't slipped yet.
So you could look stable on an X-ray, but actually be in immediate danger because of the soft tissue swelling.
Exactly. That's why any RA patient with neck pain or weird neurological symptoms like tingling hands needs an MRI.
Yeah.
Immediately.
Wow. It's really a journey of structural failure, isn't it? From the microscopic chemistry in the synovium to the bare areas in the fingers to the canary in the coal mine in the feet, all the way to this critical instability in the neck.
It is. It's a systemic collapse driven by the immune system.
Putting all this together, the clues, the tools, the dangers, what is the one big takeaway you want our listener to leave with?
For me, it's about the power of pattern recognition. RA isn't random chaos. It follows rules.
Right.
It's symmetric. It respects the bare areas. It skips the fingertips. It leaves footprints in the feet.
And knowing those rules means we can catch it.
That's the hope. The goal of modern radiology isn't just to document the destruction. It's to spot the pattern early enough. Maybe finding that one erosion in the foot or that early edema on MRI so that we can start aggressive treatment.
So you can stop the story.
We want to stop the story before it gets to the chapter with the ulnar deviation or the cervical instability. The classic signs of RA, the bent hands, are actually the signs of missed opportunities.
They're signs of failure, really.
Exactly. We want to make those signs a thing of the past.
I want to go back to one thought you shared earlier because it really reframed this whole topic for me. the bare area. We talked about it as a vulnerability, but you called it a trade-off.
It is.
It's humbling to think that the very anatomy that allows me to type on a keyboard or play the piano or wave hello, that flexibility, creates the exact window of opportunity for this disease. It's like the Achilles heel of the human skeleton.
It's the price of movement. To have a joint that moves freely, you have to leave a part of it exposed. Biology is always a negotiation between function and protection.
And in array, the negotiation breaks down. Biology is a negotiation. I love that.
Yeah.
Well, listener, do me a favor. Look at your hands right now. Wiggle your fingers. Bend those knuckles. Think about the complex machinery underneath. The cartilage helmet, the synovial lining, the delicate balance that keeps it all moving. It's a marvel of engineering, and it's something we shouldn't take for granted.
Absolutely.
Wow.
And if you do feel pain,
Yeah.
don't ignore it. Remember the patterns.
Thanks for taking this walk with us today on The Deep Dive. We'll see you next time.